Okay, good morning, everyone listening in. My name is Chimbo Richard, your host today. This morning, yonaje musinzi dokutulaba tubaniriza. In our studios, we are joined by three very important people. One is Mr. Mwebe Vincent. The other one is Geraldine Rantale, sonography specialist, practicing from the UK, though fully Ugandans. And it is a very good morning. And wherever you're watching us from around the world, you're welcome to today's health live stream, where we are going to be talking about fibroids. Now, when we talk about fibroids, it is a silent disease or health care that is disturbing a lot of women. There are a lot of misconceptions, a lot of what's being said. The causes doubtable, with everyone coming out with something to say about them. To some people, it is delay of having babies. To some people, it is family planning. To so many people, there are a lot of things they are talking or saying about fibroids. This has caused a lot of misconception, a lot of misinformation and misinformation. But on the side of women, this has caused a lot of stigma. Women fear to come out to say they have fibroids. They fear to go out to test because they don't want to be associated with a certain cause that they are not sure of. To some people, it is actually spiritual. And in some churches, they are busy chasing demons of fibroids in people. So they want to understand the role of ultrasound, especially, and maybe later a little bit of MRI in diagnosing fibroids. Again, we are honored to have two imaging specialists, people that I've known for some time, people who are good both in class and at their areas of practice. They have done this for so long, and indeed, they have both the clinical but also the practical lessons they have learned in working or serving people for this long. Our goal today is simple. We want to help you understand how imaging is transforming fibroid diagnosis and empowering better healthcare. Before we start, let me ask my panelists to introduce themselves, and I'll start with Mr. Vincent.
By the name is Vincent Mwebe, an advanced practitioner sonographer practicing with Epsom and St. Helier University Hospitals NHS Trusts, London, Sutton. And I'm happy to be here with you to have this wonderful discussion. Thank you very much, Richard, for preparing these presentations and for organizing everything.
Okay, then the lady.
I'm Geraldine Rantale. I'm a sonographer as well, practicing at University Hospital Coventry and Warwickshire NHS Trust Coventry.
Wow. So today we are going to speak English. Of course, my name is Mr.Selfcare Richard Chimboa, your host as usual, and from our studios here in the USA. So let's dive into today's discussion. From Vincent, for someone hearing about fibroids for the very first time, what exactly are fibroids? And why are they so common? And then later, Madame Geraldine, you will tell us some of the types of fibroid that you've come across in your area of practice. Yes, Vincent.
Yeah, actually, generally, to simplify everything for everyone listening, you can generally define fibroids as non-cancerous uterine growth that develop during a woman's childbearing years. Those are growth within the uterus that always come during the childbearing years of a lady. The cause of fibroids is not specific, but it could be hereditary. That's one of the causes. It could be hereditary, but it's sometimes fibroids just come. There are no specific cause of fibroids. But usually we know they come during the childbearing years of a woman. Would you want me to talk about symptoms of fibroids? Okay, let me talk about symptoms of fibroids. How does someone know that they have fibroids? Usually some people get painful periods. In some cases, we have intermenstrual bleeding within periods. Then there are cases where we have painful sexual intercourse. And for some cases, we have lower pelvic pain. There are also cases where we get lower back pain. And some ladies get heaviness in the lower belly. If the fibroids are so big, they can even cause frequent micturition or frequent in the toilet, wanting to go for wee almost every time. Those are some of the symptoms of fibroids. And if the fibroids are so small, a woman may not know until he is having some investigations like ultrasound or MRI.
Okay.
Yeah, you may have them and they can escalate without any symptom.
Another
Geraldine.
symptom could be
Yes,
another
Geraldine.
symptom could be having you sometimes you can palpate when you feel your belly, when you're touching your belly, you actually feel a hard mass. Sometimes it has been there over time, you feel like it's part of you, but when you palpate your abdomen, it's not supposed to be that hard. It's like you're pregnant, especially if the fibroid is big.
Okay.
Just to add on what Vincent has said.
Yes, Geraldine, to continue with you, what are some of the types that you've come across, types of fibroids that you've come across in your imaging practice?
So there are mainly three basic types that I've come across in ultrasound imaging. So we have the intramural fibroids, subserosal and submucosal fibroids. Now the subserosal fibroids, these ones usually grow more outside the uterus. Of course, they originate from the uterus, but they are growing outwards. Then we have the intramural ones, which are within the myometrium. Can I say within the flesh of the uterus? And then we have the ones that are submucosal. So we have a section of the uterus that is called the endometrium. The endometrium is the part that sheds off when you're having a period, or where the baby implants when you're pregnant. So the baby implants in the endometrium. So some of the fibroids grow inside, like they grow kind of pressing onto the endometrium, and those are what we call submucosal fibroids. The problem with the submucosal fibroids is that when you are trying to conceive, sometimes they can cause miscarriages. Sometimes they can even prevent implantation. That is, they prevent the baby from attaching. They prevent a pregnancy from happening. So those are some of the types that cause infertility. The other ones, sometimes, as we had said before, sometimes they go asymptomatic. You don't know you have them. Sometimes you can never know if they are very small. But of course, with if the fibroid is very big, it can actually have all the three components. If it's very big, it's pressing on it's within the flesh of the myometrium, it's pressing on the endometrium, and it's also moving outwards. So it appears like a big mass in your uterus. That's all I can say. Anything to add on, Vincent?
Vincent, as you come in, someone told me that the uterus looks like this avocado, where we have the inside, the flesh, and the skin. Vincent, using this avocado, can you help our viewers to understand the uterus that we are talking about? In simple terms, if you could describe using this avocado that I'm holding.
Actually, as my colleague has said, actually, because the uterus, we have sections, we have the myometrium and the endometrium. So the green bit is what we call the myometrium. And the central bit, which I'm describing as brown, is the endometrium, where implantation takes place, or where pregnancy implants.
Yes.
So as my colleague has been describing, of course, the most common fibroids we have are the intramural one that implant within that green section that we are seeing.
Yes.
Someone may see it as green or yellowish, or green or yellowish. Yeah. So most of
Yes.
the fibroids are within the myometrium, that green section. But we could have some submucosal fibroids, as my colleague describes, which are compressing on the brown bit. And those are the ones that usually cause heavy menstruation period and sometimes miscarriages, as my colleague has described.
Yes.
Then we can as well actually have them exactly inside the brown bit, not just compressing or abutting, but inside exactly within that orange portion of the uterus. Of course, we call them submucosal, and some people call them intracavitary because they're exactly within the endometrial lining. And we could also we have some other painful fibroids that grow outside the uterus, actually, as you're seeing that part outside, but they have a stalk.
Yes.
They have a stalk that arising from the myometrium, but they grow outside. Those ones, they are usually painful. Sometimes if the stalk strangulates, yeah, usually women feel so much pain. Of course, they are not so common, but they are there. Yeah.
Okay. So
Those are what we
yes,
call the
Geraldine.
pedunculated
Yeah.
fibroids.
The
Yes,
pedunculated fibroids. Yeah.
the pedunculated ones with a stalk.
Thank you.
Okay. So in other words, the effect of the fibroid many times is determined by where it is located.
That is correct.
So Geraldine, again to continue with you, why are fibroids so common of late? What do you think?
I would have to say that would probably best be described by a gynecologist. However, I would think lifestyle. Lifestyle, maybe, as my colleague said, genetics. And I'm not sure, but maybe because previously they would go undiagnosed, but as of course with access to healthcare, maybe women are having frequent checks. So that's why we think they are more common than before. They were probably more common even before, just that there was no access. People were not informed to go for medical services. But that's my opinion. Maybe lifestyle, maybe what we are eating. Of course, these days we are eating more processed foods. That's what I would think.
Vincent, why is imaging key to confirming fibroid diagnosis instead of just symptoms alone?
First of all, actually, there are so many reasons why imaging is key. First of all, as I said, someone may have fibroids and they may not know. And they could be just diagnosed incidentally. Someone may go for a scan for a different reason and they may diagnose fibroids, which is good because it helps in planning and knowing where they are, so that in case a woman gets symptoms in future, she's aware that she has fibroids. Then imaging helps in surgical planning in case someone has fibroids. First of all, where they are located, the number of fibroids. You should be knowing the number of
Hello?
fibroids that a lady has. In case someone is planning to conceive and has been diagnosed with fibroids, she can be advised accordingly how it may affect her pregnancy. Then, actually, as I've said, management as well, because if there's quite a number of fibroids and the size, it would help in planning. Of course, management of fibroids, like if they want to remove them surgically or they want to use other interventional procedures like embolization, it helps in planning as well. I think imaging, yeah, that's the most important bit of imaging in fibroids.
Geraldine, what are the types of ultrasound imaging that we have for pelvic or for women that want to come and do imaging of fibroids?
So in my department, we have mainly two ways in which we can diagnose fibroids using ultrasound. So we have what we call a trans-abdominal scan. So for that one, we have, I think a lot of pregnant ladies have done an ultrasound scan where you put some gel on the belly and then you use a machine that shows you the images. That machine is using ultrasound. From the machine, the sound waves go onto your belly, create signals, and then they are bounced back to the machine to form an image. And that procedure is totally harmless. It does not use any radiation. It's quick to perform. So that's one of the ways we do it. We use what we call a probe or a transducer. We use what we call a probe. We put some gel on the belly, use a probe, and create images. Another way is we use the transvaginal probe or the transvaginal ultrasound. So that one, the probe is a bit different. It's a tubular probe, which we first of all, it's disinfected thoroughly. Secondly, it's covered by a protective sheet or a protective cover. We use lots of lubrication when inserting the probe into the vagina to prevent pain or mainly for pain reduction and to avoid too much friction while you're inserting the probe. And it still that it uses the same process to form the images. Ultrasound waves are transmitted, this time to the vagina, and then an image is created on the ultrasound machine that we interpret.
Vincent, we have so many forms of imaging. Number one, we have CT, we have MRI, but for so many reasons, so many people consider ultrasound to be the first line tool of imaging in fibroid compared to MRI and CT. Why is this so?
Because we look at the cost bits of it, ultrasound is the most easily accessible imaging modality. Yeah, for fibroids. It is cheap, first of all, very cheap. And preparations are not so many and not so complicated as it could be with MRI.
Yes.
Yeah, that's the most important bit of it. And actually, it doesn't really take long because ultrasound takes a short time, MRI takes long, and MRI is really expensive. Actually, you do MRI when you really can't get what you want on ultrasound. But it's very expensive to do MRI. So ultrasound is the most easily accessible and available imaging modality almost everywhere that someone can, access.
Yes, Geraldine. In your experience, what are some of the common limitations of ultrasound in accurately determining fibroids? Okay.
So
yes, Geraldine.
With ultrasound,
yes.
So when someone has a big body habitus. That is when they have a high BMI. Sometimes when you're trying to scan, you may not get detailed images, or the image quality may not be as good as you would want it to be. That is the main challenge in my experience. Then when there are too many and too big, the uterus just looks big. Though, like that, some of the cases when they're trying to manage these fibroids, that's in some of the cases they refer the patient to do an MRI scan, which can give like a 3D image. Because sometimes these fibroids are too big, you can't even know where it's coming from, if it's impacting the endometrium. It could be very difficult. So yes, those are the main issues. Also, sometimes ultrasound is not, it's not, can I say, it's specific when some of those fibroids, you cannot know the cellular component of that fibroid on ultrasound. Some of those fibroids could actually be malignant, but you can suspect that maybe this fibroid is a malignant one in rare cases. Like, I might say that this is quite rare, because most fibroids are benign. But sometimes you have a mass in the uterus, it's looking like a fibroid, but we have some, you can put a bit of color. When I say you put a bit of color, you're trying to assess maybe the vascularity of this lesion. You're trying to see, I hope I'm not too technical now. I'm trying not to be too technical for the audience. But you can suspect that, maybe this is more than just a fibroid, but ultrasound may not be that specific. So maybe with monitoring, maybe that, which is, I've not seen it being done frequently, but maybe if you do a scan today and maybe in 6 months down the line, this fibroid that you've seen on that scan is way bigger than what you had scanned before, you may suspect it. But what I understand from MRI, it could give better clues in that regard of whether this lesion that we are calling a fibroid is malignant or not. So those are some of the limitations.
Before I let you go, Geraldine, you've mentioned about malignant and benign. Can you throw some light to our viewers to understand what simple malignant means and benign in simple terms? Because these are terms that you write in their reports. So when they are leaving Mulago Hospital, they go with a headache reading what you've written, asking border guys, and they don't understand. In simple terms, can you help my poor sister watching right now to understand simple terms what benign and malignant means?
So a benign lesion is one that is not aggressive. A benign lesion, let me start from a cancerous lesion. So a cancerous lesion, I would say, is like a parasite in the body. What I mean, it's going to suck up a lot of blood, a lot of nutrients from you. For its survival, it's going to drain your body. It's going to suck it up, suck whatever nutrients you have, suck whatever blood you have, for it to grow. It's one of those lesions that spread. So it can move from one area to another. It can spread locally or to other parts of the body. That's the best way I could describe a cancerous lesion in layman. Where a benign lesion, it does not have those characteristics. It can grow big, but it's not like parasitic, if I may say that. But of course, even if it's benign, it can cause the symptoms that we've said of discomfort, pain, and all that if it grows too big. But usually benign lesions do not spread to other parts of the body.
Okay. So
And
in
do you
other
have
words,
anything else to add on to that? I don't know if I've described the difference for the audience very well.
Actually, I think you've done it well, because actually, when, of course, just to wrap it up, simplified, you've talked of benign. Of course, when it's benign, in simple terms, it's not cancerous. So
okay.
just telling a patient that it's not cancerous calms them down. Malignance, that is cancer. And when you talk about cancer, then you are raising the alarms, because
Okay.
yeah.
Yes, Vincent. So now I know this is subjective. In your experience, are most of these fibroids malignant or benign?
Actually, most of the fibroids, like 98.8%, are benign, not cancerous.
Okay. So to everyone watching in, most times when these doctors, normally the news is given to you by sonographers, when they tell you you have a fibroid, you have chances 90, let us put say 97% that it is not cancerous. However, what Mr. Vincent is saying that there is a small percentage that it can either turn into cancerous depending on so many conditions, or it can be cancerous at that stage. So the rest of the detail now depends on if a biopsy is done, if your doctors ask you to do a follow-up, and I see how that fibroid progresses. Vincent, you were a smart student. I remember when I was at school, I used to learn a lot from you. Can fibroids be mistaken sometimes for other conditions on ultrasound scan? If yes, what are some of the common misdiagnoses? Because we have seen cases where one report reads someone has a fibroid, then they go back some other time when this person does not have a fibroid. Are there some other masses in the uterus that can mimic or be misdiagnosed for fibroids?
Of course, actually, there are not so many, but as we've been discussing, of course, if someone has, it's rare, but you can get a malignant mass. Of course, you may get a malignant mass, which could be, we could, like malignant masses within the uterus. Of course, those are the cancerous masses, which can be mistaken as a fibroid. That's the first thing. Then there is the other confusing thing. I don't know whether people are going to understand it. It could be adenomyomatosis. We have adenomyomatosis within the myometrium of the uterus. It could be focal within one area, that inhomogeneous appearance, or what we call heterogeneous appearance within the myometrium, or within that green bit of the uterus that we are showing, which could be confused as fibroids. Yeah, it is very difficult actually with ultrasound, and most of the times it can be clearly or accurately diagnosed on MRI scan. Sometimes you may have uterine calcifications, which people may confuse as fibroids, calcified fibroids. Sometimes it comes in old patients where we have calcification within the end of the uterus, or within the periphery of the uterus, due to what? Calcification of the acute arteries. You may get so many calcifications. Some people may confuse them as calcified fibroids. That could be one of the things. Then, for a patient who has had, rare cases where a patient has had termination of pregnancy, and you may get calcific components within the endometrium, which could be bone tissue, or what we could call endometriosia, it is called endometrial osteoplasia. Someone may confuse them as calcified fibroids within the myometrium or lining of the womb. Those are the very few cases that may be misdiagnosed as fibroids, as far as I'm concerned, during my experience. My colleague Geraldine can add on if she has something more.
Geraldine. Geraldine,
Yes, please.
can someone have more than one fibroid at a go?
Definitely. Uh, as we had talked before, fibroids, it can be one, there can be so many you cannot even count on ultrasound.
Mm.
Yes. They
So,
can be really, really small ones
mm,
that are numerous and you can't count them as well. Small, numerous ones. I also wanted to comment on what Vincent was, what you had uh, asked about misdiagnosis. In my
mm,
experience, uh, I've I've realized that sometimes when a patient comes with when they're unprepared for the ultrasound scan,
mm,
by this I mean that usually for a pelvic ultrasound scan that is transabdominal, as I had mentioned before, we have one where you just put the probe on top of the tummy and one where you
mm,
put the probe inside the vagina.
mm,
When a patient comes for that scan
mm,
of one on top of the tummy and they
mm,
are unprepared, that means they have not taken it, they have not filled their bladder.
mm.
We usually request patients to fill their bladder uh, for that pelvic scan on top.
Yes.
When they come and the bladder is empty, that can lead to a lot of inaccuracies or a misdiagnosis. Either a
Mm,
fibroid can be missed out, or depending on the shape of the uterus, we have shapes of the uterus where it can be anteverted or retroverted.
mm,
Sometimes, okay, in my experience, a lot of times when the uterus is retroverted, that is when it's facing backward in
mm,
layman.
mm,
It can mimic a fibroid, especially if this patient has not come prepared for the
mm,
scan. Yes, so we try our best not to diagnose patients
mm,
on an empty bladder. We will rather we'll rather have them filled. But sometimes these patients are in a hurry. Sometimes and then you offer to have the internal scan done. Sometimes they don't want to do the internal scan because of personal reasons. And yeah, you are left with like, you don't know what to do. But we do encourage these patients, if you're going for an ultrasound scan, please drink enough water to fill your bladder. An ultrasound scan of the pelvis, that is, drink enough water to fill your bladder so that the imaging technologists can have a proper view of your uterus. That's
Uh,
also what I wanted to add.
yes, Geraldine, before you go, talk about the preparation. I remember one time I was working with one of the VIP hospitals in Kampala, and one of the things actually with the challenges we used to have with the so-called corporate women was taking water to prepare their uterus. Can you throw more lights? How do we prepare for these pelvic ultrasound scans to make sure you have accurate diagnosis? And also, why do we prepare them? Then after Mr. Vincent will give us also preparation for the transvaginal scan, and why do we sometimes actually need to ask women for transvaginal scan? Yes, Geraldine.
So as I've just said, it's preparing for a pelvic ultrasound scan is quite easy. You just have to drink water or drink any clear fluid, maybe juice, whatever your preference is, to fill your bladder up. You have to feel like you need to go to the toilet for the imaging technologists to have a good view of your uterus. So you just fill your bladder up. It's simple as that. Avoid taking fizzy drinks though, because they create a lot of gas in the body. Things like Coca-Cola, Pepsi, those things that uh, I think they're called fizzy drinks. Avoid taking that to create gas, in the body, in the abdomen. But take clear fluid is fine, of your preference. So it's as easy as that. As you're doing that, women should not be afraid to fill their bladders, because as you're doing that, you're actually hydrating the body, which is also good for the body. So yes, that's simple as that. Why we
Gerald,
tell the women to fill their
yeah,
bladder. So this
yes.
So this bladder creates a window for the ultrasound waves to penetrate so that we can have a clear view of the uterus. That's all.
Okay, thank you so much, Geraldine. Vincent, where I work here, it is not a problem for women to do transvaginal ultrasound. In fact, so many times if you don't do it, they'll even ask you, oh, doctor, why don't you do transvaginal ultrasound? But in Uganda, until the time I left, it was kind of not easy to have a woman do a transvaginal ultrasound scan. Yes, we understand for so many cultural reasons and personal reasons. Can you assure every patient watching today why sometimes we need to do these transvaginal ultrasound, and what are the preparation if someone is going to do one?
Actually, before I even talk about the preparations for a transvaginal or an internal scan, in Uganda, we faced those challenges. Actually, it was because we didn't have those probes in most of the cases in the hospitals where we used to work. We didn't have those transvaginal probes. Most of the machines came with the other two probes.
Probe y'omukulu.
Yeah, that was the problem. And for some settings, in some hospitals, privacy issue was another big thing because you really need privacy for that type of scan that you have to do. Those are the main challenges. And then the sterility, because it can cause infection. We didn't have enough sterile stuff to use, like the gel and the probe covers. So, as I'm talking about the transvaginal scan, which we can call internal scan, it is a scan where we use a small probe. It is a long probe, but we have to make sure that we use it under sterile procedures, under sterile conditions. The probe is cleaned well using sterile wipes, and we use sterile gel as well. Of course, some people don't use sterile gel, they use the normal gel, but we apply probe covers on it. We cover it with the probe covers. In some settings where we don't have recommended ultrasound probe covers, we use condoms, but we are supposed to first ask patients whether they are they have any reaction, because some patients have reaction to the latex material of the condoms that we are going to use. So we should always ask patients, and we should have the two provisions of condoms to use. I should say probe covers. I think that is the best time to use. Then the other thing is getting a consent. Before we do this procedure, we are supposed to get a consent because this is an intimate scan. You're going to insert a probe into the private parts or into the vagina of the patient. So we are supposed to get a consent, and most especially this consent should be a written one and signed. Though legally we can always obtain verbal consent, and it should be documented in the reports because it can cause legal implications. Then the other thing, privacy matters a lot. It should be done under strict privacy. A woman should be given her privacy well. It should be done in a very closed area whereby no one can come into the room. The door should be closed, and we should have someone besides you. That is someone we call a chaperone besides you as we are performing that scan. Whether you are a lady performing that scan, you should have someone besides you who is a chaperone, because in case something happens, or in case a patient reports, because some patients are really complicated and some patients come with intentions. Like in UK, a patient may sue you. So if a patient sues you and you do not have a chaperone besides you, it's very difficult to defend yourself. Then the other thing, it's always good that we explain the procedure to the patient. We sit down with the patient, explain to them the procedure very, very well, what we are going to do, and they really understand the procedure very well, and they consent before we proceed with the scan. And we should also give patients options whether they want to insert the probe themselves or whether they are comfortable with us inserting the probe ourselves. So we should always give them option and they decide. Then the other preparation, so this one is opposite to the other scan. This transvaginal one, we are supposed to do it under a fully empty bladder. A patient should have a fully empty bladder. Even if a patient comes and says that my bladder is empty, it's always good for us to send the patients to the toilet to make sure they fully empty the bladder, because we've gotten cases whereby patients say they've drunk nothing, they feel their bladder is empty, and you start performing the scan, you find that the bladder is a quarter way filled, and you have to get out the probe, then send the patient to the toilet again. This transvaginal scan is superior to the transabdominal one in so many cases. If the fibroids are so small, you may not see them on top on the transabdominal scan. However much the bladder may be fully filled, I've seen this through my experience. You first do a scan on top, you're seeing very well, you can't see anything, you measure everything, you look at the lining of the womb, then you send the patient to go and empty the bladder to do the other scan, and you find that there are some small sub-centimeter fibroids that you could see, like 3 millimeters, 5 millimeter fibroids, which you can barely see on top on the transabdominal scan. So it helps out in that, even in looking at maybe small fibroids that could be intramural, it's very good. But then it's not good for a patient who has very big fibroids. Because if the fibroids are too big, then you are going to barely see, you cannot get the exact measurements that you would want. You just see one big fibroid, or you just see one mass, and you cannot orientate the probe as you would want, because that is a small area where you are supposed to move around the probe. So if the fibroids are too big, then doing a transabdominal scan is the best. Even delineating the fibroids, the number of fibroids, and if they are small enough, a transvaginal is really the best one to, not only fibroids, and actually in so many things.
Can a woman have fibroids and then they conceive? Have you scanned a pregnant woman with fibroids?
Yes, actually, there is no literature that says that if someone has fibroids cannot conceive. Majority of the patients conceive when they have fibroids, and sometimes however big they could be. Of
Okay.
course, they have implication on pregnancy depending on the size and the location. So a woman can fully conceive when they have fibroids.
Okay. Because that's one of the misconceptions out there, that fibroids are the leading causes of infertility. Again, to everyone watching now, immediately after this presentation, we are going to have a chance to host a gynecologist who is going to answer some of the questions that that are putting in the comment section. Like someone is asking, how is hormonal supplementation linked with high development of fibroids? Maybe she will have an answer if she does, because some of these require research. The people right now are imaging technologists that really are giving us the imaging part of the story of fibroids, because everything starts with diagnosis. The clearer the diagnosis, the better the treatment or the management. Again, I want to thank everyone that is watching in, and remind you immediately after here, we have a gynecologist all the way from KIU Hospital that is willing to come and discuss with us the management, what happens after these people have seen the fibroids and all that. Again, to all people that wake up every morning to start your life here every Sunday morning and Thursday morning, thank you so much. I believe personally that the more we teach our population about disease, the better information they have, then they are enabled and empowered to prevent them, not to be scared when they are diagnosed with such, but also to know what to do if they find out that they have some of these health conditions. Geraldine, Mr. Vincent earlier on talked about MRI and gave the complication, saying it's expensive sometimes. When do we normally switch from ultrasound to magnetic resonance imaging or MRI? When is that required?
Usually that's required to give a wholesome 3D image. When the fibroids are very big, there is a way the MRI classifications are a bit different. There is a way they classify the fibroid. MRI gives a 3D image. Most ultrasound, the one we use, is giving 2D. So when the doctor needs more detail, maybe in preparation for a procedure like a surgical procedure, embolization, if the condition is that concerning for that procedure to be performed, sometimes an MRI is requested for. Not all fibroids need surgical intervention. Not all fibroids need any intervention, actually. Yes, so if they are small, sometimes you don't get any symptoms. You may actually live with it if it's intramural or subserous, so it's small. No reason for unnecessary procedures. So in that case, ultrasound is just enough to diagnose, and then you just monitor if it's growing big or if it's growing big. But MRI is usually for those very big, worrisome, because if someone presents with a very big fibroid, we don't know if it has any cancerous components. Why is it that big? So MRI sometimes gives a little bit of more detail.
Vincent, looking forward, how do you see ultrasound technology evolving and improving actually to improve fibroid detection?
In fact, now we have what we call, it's improving actually nowadays because we have what we call contrast enhanced ultrasound, which helps us to give more detail about the appearance of tissues and masses, though it's not readily available in some hospitals, but in some hospitals it's readily available. So it's really helping a lot in improving diagnosing some of the uterine masses like the fibroids as we are talking about. Then for small, I think the technology is still being what improved, because there are some transvaginal probes that they use in ultrasound that are for 3D, but those ones are for uterine malformations, just the uterus, not for the masses. But I think in future they are still inventing more technology within it to help us give us some 3D appearances of the uterine fibroids and other masses. And then ultrasound, it's improving a lot actually. There is quite a lot of AI that is being incorporated with ultrasound. So it keeps on improving and improving, because what we had a few years back is not the same we have now. Because now we have contrast enhanced ultrasound. If an imaging technologist is trained well how to use that, they can give better detailed information than the previous ultrasound that we've been having.
As we move to the closure of this discussion, or as we wind up, Vincent, what do we normally tell? Because in Uganda, we have a system of people walking into diagnostic centers, and they have these ultrasound scans done. What message would you give someone watching there who went to the clinic yesterday by themselves and they were told they have fibroids? What recommendation, what would you ask them to do next? Because I know some are very worried about fibroid. Remember when I put up this post that we are going to discuss fibroid, I have more than 10 people telling me, oh, my sister was diagnosed with fibroids. Oh, we are not sleeping because of fibroids. Oh, it looks like a very big issue. And yet when you are describing here, you're saying, look, if they are small and they have no issue, they can actually be there and the patient has nothing. We are saying majority of them actually almost up to 98 point something percent are not even malignant or cancerous. So what message would you give someone that was diagnosed with fibroids and they are stuck, they don't know what to do next?
Yeah, I would recommend patients not to worry so much about fibroids, having fibroids, because they are really common. And as we've said, that majority of the fibroids are not cancers, so that's not something that should worry them. Then the other thing, I would recommend patients to really seek imaging services from appropriate, well-trained individuals, because sometimes we get scans that we are not really happy with. Of course, sometimes you look at type of reports that are being written, they're not really diagnostic and they're not really accurate. So I would recommend patients to go to good facilities that can offer better, however much it could be expensive, but it's better to get the best diagnosis once and for all, rather than moving in so many places, being told different things. And then I would also recommend patients to seek attention or to seek guidance from appropriate practitioners or specialists. Because if you are told that you have fibroids, it's good for you to have a very good detailed report and get an attention of a gynecologist. He would advise well. That's what I would recommend patients. Because I always see patients going to doctors, going to people, asking everyone have fibroids. They aren't going to help in one way or the other. Of course, you just keep on getting more information. Some people will end up giving you this information, the other people will give you, and you end up being scared. So I would recommend patients to once and for all go to specialists. If you have fibroids, go to a gynecologist with a report well written. He will advise accordingly, and the gynecologist will reassure you well. But all I can tell patients is not to worry about fibroids. They are not killers that you're going to die of fibroids. Of course, if they are so big, you may get discomfort like pain, and sometimes, of course, they can cause miscarriages if they are too big and depending on where they are. But that's not something that should worry so much about, that you're going to die of fibroids. All I can advise is to seek medical attention from appropriate medical practitioners.
Yes, Geraldine. As we conclude, we are really coming to the very close of our program today. Have you heard about that someone was bewitched to have fibroids? Have you heard those stories?
But those stories are not true. Please
Nti
go and
bamuloga ekizimba?
well, those are misconceptions. But I just encourage every lady to have sex instead of accusing people of bewitching them. Have sex. Go use the facilities that we have available.
Did you say to have sex?
No, have sex. Have examination. Have yourself checked up.
Okay.
Yes, have yourself checked so that you don't have to accuse people to to have time to bewitch you. Some people always run to that.
Yeah.
Go and get checked. Go and do whatever is necessary to get yourself treated, not only for fibroids, but for any other medical condition. These regular checks, there are those annual checks that you can get, like a full body workout, a full body checkup. That's what I would recommend for people to do.
And then also, lastly, Geraldine, what will be your recommendation for a lady there that is worried about misdiagnosis they checked them, they told them they have fibroid, they are not sure if there was misdiagnosis. How would you comfort them and what would you recommend them to do?
So if you are really concerned, you can always, first of all, I can say is that it's rare that fibroids are misdiagnosed, especially if the technician is competent. It's rare that fibroids are misdiagnosed. However, if you are concerned, you can always seek for second opinion. There is no harm in taking a second opinion. That's what I would say.
Okay, so Geraldine, what are your closing remarks as I set you to leave the panel? My internet tells me you're needed somewhere, so send your closing remarks and then I'll set you go.
Well, I'm thanking the viewers for watching, for being proactive with their health.
Yep.
And I encourage viewers to always be proactive with their health. That includes going for regular checkups as well, not only for fibroids, but mental checkup, hypertension, any non-communicable disease, cervical screening. Just people to be proactive with their health. And I thank you for hosting such programs that could give more information to viewers so that people take charge of their health.
Thank you so much, Geraldine, for accepting to be on a short notice. And please, each time we call you on a Sunday morning, we know this costs you a lot of dollars. You could have been somewhere making lots of money. Thank you so much for having us and for loving your country and for sharing. That one person or two ladies that listened him, I believe, learned a lot. So have a good day and enjoy the rest of your day.
Thank you.
Yes, Vincent, as we finish up or conclude on this, what are some of the challenges that we are experiencing in our Ugandan setting when it comes to pelvic imaging or imaging of the pelvic? Because I've had cries and I have reports here in my inbox that there are so many misdiagnosis happening there. What's your advice to colleagues of ours that are doing ultrasound scans locally home in trying to curb these complaints down?
During my practice in Uganda, actually, I realized that most of the scans we do, pelvic scans, we do them on top. They are transabdominal scans. But to be honest, they give really little information. Transabdominal scans are giving very little information, like 40% of what we would want to see. Even if a patient is slim enough and has a fully filled bladder, because I've done it myself, I've really experienced it myself.
Yeah.
You do a general scan on top of transabdominal scan, you look at normal things, but when you do transvaginal scans, you find that there are some things you hadn't seen on top. However clear it was. So we still have some problems in Uganda that we don't have transvaginal scan services. And it doesn't really help at all, actually, for ladies. That's why I think we've diagnosed, actually, cervical cancers in late stages. That's one of the things I think because we used to scan patients whereby you could get patients with cervical cancers in stage 3 or 4. Because there are some small masses that you may not see transabdominally on ultrasound. Of course, usually we start from what we call polyps. Because if a polyp is seen, we call it a polyp on ultrasound, but definitely they have to intervene with an interventional procedure, like they have to do laparoscopic procedures, or they have to put a speculum and get that polyp and take a piece of it. Some of those things we cannot even see them. We've seen endometrial cancers, but you're not going to see endometrial cancer on ultrasound transabdominal if it's still in its early stages. You see endometrium, well, you just mentioned the endometrium is okay. But if you're doing a transvaginal scan, any endometrial lesion, you would see it however small it is. And now it's even improved. We have infused ultrasound whereby we inject fluids. And you can see those small polyps, what we call polyps. Of course, we always call them polyps, but they can only be confirmed to be polyps after they've taken them out and done histology on the samples. So we miss so many cases, actually malignant cases, by doing scans on top. So I would recommend, I don't know whether if the government could help even the private service providers to have transvaginal ultrasound services too, on top, and transvaginal for every gyne patient in case they are not vagal intact or in case they are sexually active and they consent. As per the gynecology guidelines, every patient should have a transvaginal scan if it is a pelvic scan. That is what is recommended internationally and by the World Health Organization. Doing a abdominal scan only, it does not really give information that we would want. We miss out quite a lot by doing only transabdominal ultrasound examination. Even some pelvic masses can easily be missed. You do a scan very well and you cannot see a pelvic mass. I mean an adnexal mass just besides the uterus. Because you can even experience it by, like me, when I'm scanning. You scan on top, you are looking at the right side of the uterus, that's the right adnexia, and the left side of the uterus, the left adnexia. You cannot see any cyst or anything. But by the moment you insert a transvaginal probe, you can always see cysts that you weren't able to see. Of course, now we even have cases of ovarian cancers. So those things can easily be missed out. You can see a cyst on transabdominal, it looks a simple one. But the moment you insert a transvaginal scan, it looks very different. It's not a simple cyst or it's not a simple follicle as you thought on top. Endometriosis cases, most of the endometriosis cases are missed because people describe them as cyst, or I used to see whether by people who describe tubovarian mass, tubovarian cyst. So many of those ones. By doing an internal scan, you see it's an endometrioma. A patient is having endometriosis issues, we call them tubovarian masses. That was the most common diagnosis. Even simple follicles.
Actually, Vincent, you come to speak about that. I think ever since I changed the location, there are diagnoses that I've never seen here in the US. I've never seen a diagnosis of tubovarian mass. I've never seen it for the 2 years I've practiced here. And so, again, what you said is true. I've also observed an ectopic pregnancy that was missed 2 times on transabdominal. But when we put a transvaginal, this was almost coming to how many weeks? 9 weeks. So what you're saying is very true, that when it comes to accurate diagnosis, especially pelvic examination, fibroids inclusive, we really need to put emphasis on transvaginal. To the guys operating private health facilities, we know you want to make money. But if you want to make money, make sure you invest in a proper ultrasound machine. A machine that has color Doppler, a machine that has at least a transvaginal and the other curvilinear probe. Because like Vincent, I said, we are missing a lot. Sometimes not because the radiographer or a sonographer does not know, but that's the machine he has. We are forcing them actually to see diagnosis they are not supposed actually to confirm with the machines they have. So as we are advocating for better imaging, for early diagnosis of diseases, let us also try to invest money in the right machines. The machines are becoming cheaper per day. So let's invest, because there is a lot of we are missing. Vincent, is there an advantage of detecting fibroids early enough compared to detecting them later in?
Yeah, of course, one of the advantages of detecting fibroids early enough is if a lady is planning to conceive, because some fibroids are going to cause miscarriage depending on where they are. Because if someone has what we call an intracavitary fibroid, which is within the endometrial cavity, and the lady is planning to conceive, it would be recommended that it's removed first. Or if it's is submucosal, that is just abutting the endometrium or pushing the endometrium. Those are fibroids that can cause miscarriages. So in case they are diagnosed and they are seen earlier, and the woman is planning to conceive in future, she can be advised accordingly that this could cause this, or it could cause this, and they could even be removed before she conceives, so that she does not get miscarriages. So it helps in that way. Actually, throwing more light on what we've been talking about, actually, let me just put more emphasis on it. When you are still talking about transvaginal scans, ectopic pregnancies, that's where you're going to get problems. You are going to miss so many ectopic pregnancies, and we are going to misdiagnose. Ectopic pregnancy, you're going to miss quite many, like 90%, by doing transabdominal scans. Yeah, I want to throw so much light because it's caused the litigation to so many people here in UK. Yeah, because a patient can even die because of ectopic pregnancy. So yeah, I want to throw more light on it. Doing early pregnancies, all the scans should almost be transvaginal, most especially when you cannot even see pregnancy within the uterine, within the endometrial cavity. It's a must that you must do a transvaginal scan, because you may get pregnancy of unknown location, or you may not even see it, but they may even keep doing the beta HCGs and they keep on increasing. That pregnancy could even be ectopic, but you may not even see it by doing a transabdominal scan, and those tighter values could keep increasing, patients getting pain. A patient could be just taken for a major surgery because of nothing, yet they could have done laparoscopic surgery. As you know, in Uganda, our settings, the way they do things. So I want to put more light on that. Richard, you are still continuing.
Wow. Thank you so much for that, because sometimes I feel sorry for our for sonographers everywhere, like, and also the patients. Please, patients, transvaginal scans don't hurt. They are not meant to embarrass you. They are not meant to disrespect you. But like Vincent has said, if you ever go for a pelvic scan, consider it incomplete and a transvaginal scan has been done. Unless you're talking about pregnancy in the second trimester, 14 weeks and above, or when the pregnancy is fully in the uterus, nothing to worry about. But each time we have patients with the symptoms, be it pregnancy symptoms or pain symptoms, and we've done a transvaginal abdominal scan and we think it's normal, please give yourself trouble, an extra mile of doing a transvaginal scan, because it is going to reveal things that you least expect. I've seen that practically. I've done scans on transabdominal and everything is okay. You put in a probe, you're seeing polycystic ovarian syndrome that you actually you are not seeing. You're seeing things that you're not seeing on this other scan. So friends working in the sonography department, again, everywhere, whoever is watching, let's always add a transvaginal ultrasound scan on top of the transabdominal one to make sure the patients live with a right diagnosis. Last question. This one is asking, Doctor, what are some of they tell us that MRI has a lot of radiation. Is that true, Vincent?
No, MRI doesn't have radiation, actually. MRI does not have a radiation. It's CT scan that has radiation.
Okay.
MRI does not have radiation and should not really scare you, but you should prepare for it. You should not have any metallic objects because it's contraindicated for that. So you should mention whatever you have, whether you have any implants for the MRI. That's the only thing, but it's not having any radiation. It should not worry you at all. Oh. Then, Richard, before I even proceed,
yes,
you talked over. I would want to advise my fellow sonographers, in case you're working in settings where you don't have transvaginal scans, please put a disclaimer on your report. By ending your reports, it will save you in one or the other. Because remember that you own these reports. Whatever you write, you own it. And most of the times you find that the gynecologists or other consultants depend on our reports to proceed with whatever they want to do. So if you don't have transvaginal scan services, please put a disclaimer and recommend that you would want it to be done for more accurate diagnosis. It could be done from somewhere else if you don't have it in your settings. So you really need to be sure that you are safe. We need to have what we call safe practice. Yeah.
Again, Vincent, you've talked about gynecologists. This is the last interactive question that I'm having with you, and then I'll set you go. How important is this sonography report to whoever, to a gynecologist reading it? Because to some people, it's just a paper. But how important and strong is that thing we call a report that we always give our patient to take back to their doctors?
Actually, this report is very, very important because sometimes you find that the gynecologist cannot proceed with the reports because that would just be witchcraft. You cannot proceed because, of course, they can. Some gynecologists have experience in what they're handling, but like cases like ectopic pregnancies, how is the gynecologist going to help himself with ultrasound scan services? And they're suspecting patients are pregnant. How are they going to start managing them without ultrasound? However much they've done HCGs, because you may do HCG and it could come out positive, but the pregnancy may not be in the right place. So gynecologists actually they depend entirely mostly on ultrasound services for most of these cases. Make sure that you write your reports well and make these reports simple. Please, let's not complicate reports. Sometimes we complicate reports for ourselves and for the patients and for the gyns. Just make reports simple. Describe where the pathology is. Measure the sizes. I always recommend to measure in 3 dimensions. Make it very simple. Don't complicate it. I see people want to write very complicated reports. When someone reads it and says, "Oh, this is a very report from a very good sonographer." A good sonographer is not judged by writing complicated reports. Actually, you should write very simple reports. Describe what you describe in simple terms. It eases your work and eases the gynecologist's work. Give them the location where it is, the sizes. That is it. Yeah.
Okay. Thank you so much again, Vincent, for being with us today. And I know it's been a busy time for you. You've just had a very important function of your life. Again, congrats on your recent wedding.
Thank you very much.
Thank you so much for accepting to be on the panel, straight from honeymoon or even still in honeymoon.
It's my pleasure.
What are your closing remarks? I know you're one person that has always watched all the episodes of this program ever since I started, and you always respond back. What are some of your remarks to someone that has watched this presentation on the imaging of fibroids, to a sonographer that has watched it, but also to someone that is just watching about imaging and fibroids?
Yeah, first of all, I would want to thank all the viewers for having sacrificed their time to watch us and to get to learn more things about what we've been discussing today, mostly fibroids, as it's been the topic today. Thank you very much for sparing your time and for giving us your attention. Please, what we do, of course, we also sacrifice time to come and give these presentations here. I would recommend you to please continue, if you can, watching these talks and following whatever we do, because it helps you a lot and it impacts on your well-being. Please watch whatever is being broadcasted, get to learn something, because you're getting this information from the expertise. I see so many people getting information from so many people, propaganda somewhere. So it's not good to base on propaganda and to get misguided information. So it's always good for you to come and get the knowledge from the expertise. It teaches you a lot and opens up your mind, and it helps you know what to do next time in case you encounter a case that is similar to what we've discussed about. And it as well helps you a lot to know where to go in case you have some cases, and in case you've been having some symptoms of whichever cases that has been discussed. At least you will have a clue on what to do and where to go, and sometimes how to manage it and who to consult. Secondly, I would want to thank you, Richard. It's really not very simple to organize these talks. You really sacrifice a lot. I've been seeing so many now. There are over 100 talks that you've been organizing. In your schedule that you have, you really sacrifice a lot of time. I thank you a lot for organizing and for doing this with compassion, because you're not being paid for this, for loving your country and for loving the community by organizing this presentation from various expertise, gynecologists, dentists. I've seen so many talks. I've been following quite a lot that you've been organizing. Thank you very much for impacting the community. This impacts the community quite a lot, and so many people are getting to learn so much from this. Some people don't know what's really going on when it comes to medical things, but I've seen people getting to learn so many things from the talks that we've been organizing and from all the people that we've been hosting, all the experts.
Yes.
Thank you very much, Richard, and please keep it up. You are impacting the community. I don't know how they can pay you back, but God will pay you back.
Amen.
Keep it up, please.
Thank you. Again, we've learned today that imaging through ultrasound and MRI is not just about seeing fibroids, but about guiding treatment and ensuring women get the right care at the right time. As the saying goes, the clearer the picture, the better the decision. When it comes to women's health, imaging brings clarity, and clarity is going to save lives. Again, thank you so much, Mr. Mwebe Vincent and Miss Geraldine in absentia, and our audience. Don't forget to share this, to like, and to comment. And again, to everyone that has seen this video to this very time, thank you so much. I believe your data has been well spent. Our role is to speak. Our role is to empower you with information. The decision still remains in your hands. Like I always say, self-care starts by knowing a few things about your body, how to feel. That's why Mr. Vincent took us through the symptoms, so that when you see some of the things, you can tell that my body is not fine. I think I have a fibroid, or I may have. When we have self-awareness, when you know about your body, when certain things happen, you're going to seek assistance from medical facilities. Again, go to proper medical facilities. I've seen trending stories. You're sent to go to Mulago, and instead you go to places near Mulago. You're sent to go to say a certain department, but you find a bigger line. Then someone wants to give you a shortcut and it takes you to a kiosk in the name of a clinic. And the wrong procedures are done on you. Then you come out to complain. Sometimes I feel bad for you, but I keep asking myself, how do you leave a bigger facility and you go to a small kiosk nearby? Because you want to quick things. It is your number one primary responsibility to keep your life and to protect it from all quacks, all people that masquerade as medical practitioners. It is your number one responsibility. I want to thank all the health practitioners serving in both government and private hospitals. Thank you so much. To me, you're heroes. To me, you should be celebrated every day, whichever part of the world you're coming from. To me, you're doing an amazing job. To our dear patients that stick to guidelines as we give them, thank you so much. And to those that always take time to pray for that nurse, for that assistant person, for that radiographer, for that doctor, prayer works. I believe that people who love me pray for me. So to all our dear patients, continue praying for your healthcare providers. Sometimes they go through a lot. Sometimes they are thinking they are struggling with life, but they choose to do that noble cause. Thank you so much. Whatever you do, in whichever way you do it, always remember self-care first. Take care of your body first. Prevent infections, make your body stronger, and when you don't feel fine, always go to the right practitioners to seek medical services. Thank you so much, and until next time, have yourself a good day. And also a reminder that at 10 a.m. today, we are going to have a discussion with a gynecologist all day from KIU, Dr. Faith Nabushao, who is going to add to what the imaging technologists have shared. They have shared how to see masses. She's going to start from when we see them, what happens. So you wouldn't love to miss such a conversation. From everyone at Mr. Selfcare Studios, thank you so much and have yourself a blessed Sunday. May God bless you.
Bye.